to immunity, basically, it's triggered not only by noxious stimuli, but also by things that should not be dangerous, like mites or pollens. And basically what happened is the disruption of the epithelium, the activation of the immune system, as we saw. And this, for example, just taking the example of asthma, will bring to some, let's say, reversible and irreversible consequences from the airway epithelial inflammation, the production of edema, recruitment of cells, globate cells, hyperplasia and mucus production, increased contractility and hypertrophy of like the smooth muscle, and bringing at the end to fibrosis and airway modeling, where the damage become irreversible. Okay, so this is what happened basically in the asthma pathogenesis. Everything rotates around the key early cytokines of T2 inflammation that are able to orchestrate a lot of the events that bring at the end to the irreversible damage. And similar things, of course, happen in atopic dermatitis. Similar, I'm not saying the same. The triggers comes from the disruption, of course, of the epithelial barriers, so the stratus corneus, in which allergens and irritants can penetrate the skin, activate an immune response that is shifted towards Th2 response, as we'll see later, and this brings to a chronic stage of irreversible damage. So, are these things the same or not? Inflammation in asthma and atopic derm, we always call T2, but is actually the same? Actually, no, okay? It's similar, but it's not the same. The role of lymphocyte, for example, in asthma is mainly driven by B cells, okay, with the participation of T cells, of course, while atopic derm is mostly a T cells driven disease. IgE, we know that they are pathogenetic in asthma, while in atopic derm are probably a marginal role, not so relevant. The Xenophiles, yeah, in asthma, probably they have a key role. And how we know that? Also because killing them, so removing them from the picture, will improve the asthma, as we'll see during this conference. While in atopic derm, anti-IL-5 are not really working. And IL-13, so another one. In asthma, yes, very important, but even if we stop it, asthma will not improve. While in atopic derm, this thing will happen. So let's see our key actors. So the alarmins are crucial. Most of us know very well the cytokines, IL-4, IL-5, but have little knowledge about these early signal. So IL-25 is basically always expressed in epithelial and endothelial cells, and is further produced after damage, and is able to directly activate the innate lymphoid cells to start the immune process and the response. IL-33 is constitutionally expressed inside the cell's nuclei, and when the cells is damaged, is released in the tissue around, and is basically to activate to an interleukin-1 like receptor many signaling pathways, and its level correlate with asthma severity. So it's not only isolated cellular process, but it has also clinical consequences. And TSLP, that, I mean, I guess most of you knows, and we'll probably get to know a lot in the next year. So it's basically produced by epithelial cells when they are triggered and stimulated, and can be highly expressed on skin in atopic derms, and basically is able to direct activate multiple cells. So this is what happened basically with the early alarmin. As we see, many different cells are involved and activated by the early release of these mediators. And the very important thing is these are not dependent upon antigen recognition. So the tissue resident cells, ILC2, dendritic cells, and mast cells, of course, they have different role, but their common things is they are embedded in the tissue. Dendritic cells are the main APC. Okay, also Langerhans cells might have a role, but dendritic cells is the key actor here. It's basically uptake the antigens from the epithelium through transcytosis, and is able to activate the lymphocyte inside the lymph nodes and skewing the inflammatory response towards a Th2 phenotype. ILC2, very important key resident cells are activated by in an antigen-independent mechanism. And of course, they are activated by the alarmins that we saw and are able to release classic type 2 cytokines. So they are able to start the response very quickly. And mast cells, of course, they are resident, they are long-lived tissue, they are able, yes, as a final actor of inducing tissue damage, inducing edema, but they are also able to further propagate the response by releasing the cytokines. So, okay, let's quickly go on. Okay, just to show you the role of ILC2. So they basically, these cells are crucial, are a central actor in the process because they interact with many other part of the inflammation, of type 2 inflammation. Okay, the eosinophils. The eosinophils are generated in the bone marrow from a common precursor, and their trafficking is complex and tightly regulated. IL-5 is basically the main eosinophilic cytokine, is able to induce their production, is able to induce differentiation and activation. But other cytokines are very important because for migration into tissue, you need exposure of specific adhesion molecules, and this is boosted by IL-4 production and IL-13. So the eosinophils, once in the tissue, can create damage by production of enzyme that damages the tissue. So why? Okay, eosinophilia is important. Yes, of course, everyone knows that. It correlates with the severe persistent airflow limitation in asthma. So you see that eosinophils level in peripheral blood are significantly higher in patients with a severe obstruction compared to patients without obstruction. And also they correlate with the low expiratory flow. So the higher, the lower is the expiratory flow. And as we see here, peripheral blood eosinophils level do correlate with asthma severity and with the overall, in a negative way, with the overall asthma control. Other actors are IgE, of course, classic like immunoglobulin molecule with that is produced by B cells through isotype switching in the presence of IL-4 and IL-13, are able to activate mast cells and basophils. And of course, they are a marker of a T2 phenotype, but they do not correlate with the severity. Okay, this one we'll skip. Here. So what are the therapeutic opportunities that we learn by knowing the type 2 inflammatory response? So we see here that, okay, we can intervene, we can act on IL-5, for example, with mepolizumab or reslizumab. We can act on IL-5 receptor on the eosinophils with benralizumab. We can act on the IgE, so blocking their pairing and the engagement with the receptor with omalizumab, and we can work on IL-4 and IL-13 with dupilumab, or only with on IL-13 with lebrikizumab. And in the next future, we can act on TSLP with tezepelumab. So there are plenty of opportunities. Most of them also possibly in the future will be explored, and new opportunities will have. So let's skip to the conclusion. Okay, so our understanding of type 2 inflammation has increased a lot in recent years. Okay, there are many different actors, of course, that have a very complex network of interaction, and this involves epithelial cells, natural and adaptive immunity. The alarmins, so epithelial cells-derived cytokines, are very important and essential in initiating and polarizing early the response, while the classic type 2 signature cytokines, IL-4, IL-5, IL-13, they are the core perpetrator. They like promote, increase the inflammatory response and produce the damage on the long run. So in addition to the well-known role of dendritic cells, T and B lymphocyte, eosinophils and mast cells, we know now that ILC2 are very important cells for the early initiation of the response. We know also that despite having a lot of similarities. Type 2 response is not the same in every organ and in every disease, as it might be different depending on the organ that we are talking about. And of course, better understanding of type 2 inflammation led to multiple therapeutic options that we have. Just imagine how different was 10 years ago, our therapeutic possibility in type 2 disease. And of course, the knowledge that we are gaining with the use of these biologics will allow us to produce more options for the future and to better understand type 2 inflammation. So just want to close this with a very quick example. So when you know little, you might have an idea that things can be simple to understand, but as you move farther, you see that the larger picture actually it's much more complicated to understand that what you thought at the very beginning. So complexity, at the end of the day, is beautiful, and life, we have to accept the fact that life is complex and we have to learn how to deal with it. Thank you for your attention. Sorry if I had to rush.